Bismillah Rahman Rahim. Dr. Bilal Mehman here, urology resident, and I'm going to present a topic of today's presentation of mine in cone urology, that is the UTI in children. Now, the learning objectives of a presentation is our pathophysiology of the infections in the children and how to assess what are the investigation lines of the child suffering from the UTI and what is the management of the UTI in the children. Now, first of all, we should know, we should throw the light on the definition of the UTI, that what is a UTI. UTI is basically the inflammatory response of urothelium that is to the microorganisms, and that is usually concomitant. There is a bacteria and a pyuria and a significant number of organisms or the inflammatory changes within the urinary tract. Now, uh, what are the types of UTI? Basically, the UTI, whenever it occurs in the recurrent form, it manifests in several ways, like there's unresolved bacteria, there's a bacterial persistence, or there's a reinfection. So, anyone from the class can tell me what is the unresolved bacteria? Anyone, any volunteer who can tell, who can define what is unresolved bacteria? It is clearly written. You can have an idea from this pic and then narrate your from a point of view that what is unresolved. Yes, Dr. Adnan.
But there is bacteria and we have antibiotics and that is not allowed.
Yes, it's correct that in the case of unresolved bacteria, whenever we are giving the bacterial therapy, and this bacterial therapy, it will not be effective in eradicating the source of the bacteria, like whenever there is a malabsorption of the drug, like there is a non-compliance to the drug, like there is a resistant uropathogen, and there is a suboptimal drug metabolism. Now, in the case of bacterial persistence, what happens that when the urine culture it is labeled as this, it becomes negative after giving the antibiotic therapy, but the nidus causing the UTI, urinary infection, it persists and it is labeled as the bacterial persistence, and it will whenever it will get the chance, it will again start seedling and ultimately resulting in infections and disastrous consequences. Now, the relapse and the recurrent UTI. The In the case of reinfection, whenever there is an this the UTI which is the recurrent, and it is this which is caused by the different pathogen at any time. But in the case of relapse, the recurrent UTI caused by the same species.
Another thing, how can we define the recurrent UTI? Even from the audience, what is the recurrent UTI? How can we say the child or patient is recurrent?
3 or more time within a 6 month period.
3 or more UTI in a 12-month period, or 2 or more UTI in a 6 month. Then we can say the patient is having a
Recurrent UTI. Now, the significant bacteria, it is defined as the presence of greater than 10 to the power 5 bacteria per ml of urine. And the asymptomatic bacteria, whenever there is an passage of bacteria in the urine, but the patient or the child has got no symptoms, he is asymptomatic, that is known as asymptomatic bacteria. While while the urethritis, basically, we are giving the just a, brief light on definitions, and then we will discuss regarding what is the pathophysiology of the UTI and what are the investigations, and then what is the management point of view. In the case of urethritis, there is an infection of the urethra causing the dysuria and urgency and the frequency. And in the case of cystitis, whenever there is an infection and inflammation in the bladder, it will result in the dysuria and the frequency. And in the case of acute pyelonephritis, there's acute infection and resulting in the different clinical manifestations, like the patient will have that fever and painful micturition and the symptoms and signs of UTI and the pyuria. in the case of chronic pyelonephritis, whenever there's inflammation of the kidneys, and that is because of the recurrent UTI, that is because of the VUR, resulting in the scarring. Now the epidemiology.
That can anyone tell what is the complicated or uncomplicated UTI? Must have read. Most of you have been through the beats rotation. You have seen patient. What is the complicated and uncomplicated UTI?
Complicated is the one which is associated with functional or anatomical abnormality
Yes.
of the body. Uncomplicated should be normal to
Yes. And complicated whenever there is no anatomical or physiological pathology. So whenever a child presents to you with a fever, your caregiver provider, you must look for some signs in the child, whether it's a toxic child or sick child. So you have to differentiate: is this child needing immediate attention? Because the fever can be because of the other causes as well in the child who actually pediatric patient. So can anyone tell what are the signs of toxic child or sick looking child? Whenever you find those signs, you must become very alert and immediate attention to the patient. It is very important because whenever you are in ER or whenever in your rotation or whenever you see a child present with a febrile UTI or present with a fever, so what are the clinical signs that you look that toxic or sick looking child? Yes, Dr. Misal.
Something eyes.
I would be hydrated already.
Yes.
Definitely. And the patient is very the patient is feeling or not.
Can be a mic, can't hear.
Sunken eyes, signs of dehydration, and if the child is feeding adequately or not. Any signs of irritability,
Yes.
responsiveness of the child,
Yes. And
tachycardia, tachypnea.
yes, you look for hyperventilation, you look for cyanosis, you look for the eye contact of the child. You must inquire the parents if child is able to feed properly or not, or is he responding to your eye contact or not. If you find any of those signs, you must become very alert, and you must pay immediate attention to this child because these are the signs of toxic or febrile child.
Yes, regarding the epidemiology, actually the risk of bacterial infections, if you are comparing the male child with a female child, before the age of 1 year, the incidence of UTI, it is more in the male child as compared to the female one. And after the age advances, the risk of UTI, it becomes even 10 times more in the female rather than the male. And the basically the UTI, they have got different types of the manifestations and the long-term sequelae, and we will define these sequelae in our next and subsequent slides in the detail. And Dr. Misal very well told regarding the definition of the sick or toxic child, that the child having the cyanosis or decreased activity, hyperventilation, and inability to tract or irritability. And the clinical significant fever, when the child is suffering from the UTI, we must know that along with the presence of urinary symptoms, we must know that what are the other parameters and labeling the child suffering from the UTI. When the child has got the elevated the rectal temperature of 100.438 degree Celsius or higher, and when the regarding the inflammatory markers which will prove that the child is suffering from the UTI, like the elevated WBC and elevated ESR and the C-reactive protein and the procalcitonin. While procalcitonin, it has got more sensitivity and specificity in the labeling the child suffering from the UTI as compared to the CRP.
Whenever child presents, what are the further questions? What are the other symptoms you look for? What are the other causes of UTI in a child? Yes, we are urologists, so we must be evaluating for UTI. But what are the other causes of fever in a child? Those who have done PEDS. Yeah, Dr. Tanvir. These are the signs. What are the other causes of fever in a child, which are very common? We must ask every parent. Yes, Dr. Nadia. Yes.
Upper respiratory tract infections and
So you must ask if the child has any runny nose, any sore throat, any earache, any altered bowel habits, because most common causes are viral illnesses. So if a child present with a fever, you must ask about these questions as well, apart from urological questions or urological signs.
Now, the signs already described, like having the subpropelvic tenderness, or having the patients have got a sinuses or irritability, and regarding the symptoms, older than if the child is speaking and giving the verbal notation of the UTI, like suffering from this dysuria and frequency and urine incontinence, all are predictive of UTI. Now, regarding the clinical examination of the child suffering from the UTI, and basically we will first of all will have the general physical examination. On the general physical examination, the child, we should first of all go through the vitals of the child, and then through the subvitals, and then we should start from the abdominal examination. And in the abdominal examination, we have to look for the any abdominal mass or bladder distension, or for example, if the child is suffering from the recurrent UTI, that is because of the anatomical anomaly or any obstructive cause, such as the posterior cerebral valves, or as the patient will have the patient can be in the retention and have the bladder distension, or whenever there's any obstructive uropathy, the patient will present with the flank pain with the obstructive kidneys resulting in the hydronephrosis. And in the external genitalia, we have to look for local irritation or urethral metastenosis. If there's a metastenosis, definitely there will be uh, uh, the retention. And regarding the anatomic anomalies, now in the case of genital examination, we have to look for the testicular tenderness, which is a sign of epidermolysis. And in the case of female, we have to look for any, and then in the cautious, we have to look for any discharge or any prolapsing mass, such as the uretrocele. In the case of examination of the back, we have to look for the presence of neurogenic bladder, like the child is suffering from the neural tube defects, such as the spina bifida, and having the sacral fluid behind, and then the patient will be suffering from the UTI because of the neurogenic bladder. Now, the risk factors for the urinary infection for the UTI, such as the female gender, but as the age progresses after 1 year, the chances of UTI in the female gender are more. In the case of uncircumcised child, male child, and the VUR, avoiding dysfunction, obstructive uropathy, the urethral instrumentation, and wiping from back to the front in the females, because the females they've got mostly the short urethra, and this wiping of the from back to the front, it may resulting in the contamination and the bacterial infection and ascent of UTI within the urinary tract, and resulting in the sequelae causing the urinary tract infection, like the constipation. The constipation we will describe regarding what is the bladder bowel dysfunction, and this the constipation, why the constipation is causing the UTI, and the bacteria having the P. fimbriae, and the anatomical anomalies, and the neuropathic bladder. Now, etiology, the most commonly this UTI is caused by the E. coli, greater than 80% of the cases. While in the minor cases, it may be by the enterococci and staphylococci, streptococci, and then friends mostly the enterococci. The clinical manifestations of the UTI are the pyelonephritis, the cystitis, and asymptomatic bacteriuria. Now, before going into the clinical manifestations of the UTI, such as pyelonephritis, such as the cystitis, and such as asymptomatic bacteria, we must know regarding the pathophysiology, how this bacteria it will cause the pyelonephritis, the cystitis, or even the UTI, because there are certain factors of the microorganisms and certain host factors. The factors of microorganisms causing the UTI, such as the presence of the P. fimbriae, as I described in the previous slide. Now, what happens is the bacteria, it has got more than 80 types of this P. fimbriae, and through this P. fimbriae, this UTI, this bacteria, it will attach with our lower, such as, for example, if it is ascending through the urethra into the bladder, in the bladder, this through this P. fimbriae, it will attach to the superficial umbrella cells of the bladder. And when it will attach to the superficial umbrella cells of the bladder, this bacteria, it can form the intercellular bacterial communities, and these intercellular cellular bacterial communities, along with the presence of this P. fimbriae and capsular polysaccharides, it will result in the formation of the biofilms. And through this biofilms, the bacteria, it is more amenable, it is resistant to the treatment, and it will survive for the longer period of time. And through this uh, pathway, this the bacteria, by the presence of other factors, such as, for example, the arobactin. The bacteria has got another factor for survival, the arobactins, because the need of electron transport, or need of DNA synthesis, or need of oxygen transport in the bacteria is more important for its survival. And so this through this arobactin, it will suck out this iron from the iron storage points within the host. And another factors like the capsular polysaccharides, through this capsular polysaccharides, this bacteria, it can assume the transformation which is more resistant to the antibiotics. And from this, when it will form the when it becomes more resistant to the treatment, the bacteria, it will ascend through the ureters upward in the upper tract in the kidneys. And in the kidneys, the bacteria, it will release more of the cytolytic enzymes, resulting in the dissolution, and ultimately the pyelonephritis. And if the patient will have the recurrent UTI, recurrent episodes of UTI, ultimately these organisms, they will result in the renal scarring, hypertension, and other sequelae of the chronic UTI. Now, in the case of the pyelonephritis, whenever there's an UTI, upper tract UTI, the bacteria, it will result in the inflammation of the pelvis, and which is characterized by the different signs and symptoms, like the patient will have got the abdominal and the flank pain and fever and malaise and nausea and the vomiting and occasional diarrhea. On examination, the patient will have got the costovertebral tenderness and suggestive of this pyelonephritis. Now, in the case of the diagnosis of the UTI, we will have certain investigations like the urine analysis, like the urine dipstick test, like the we have the UNDR, urine culture. In the case of urine dipstick test, it will help in evaluation of the UTI by having the leukocyte esterase and the nitrite. What happens that whenever there's the release of this the bacteria in the urine, and there's an release of along with it there's a release of white blood cells, and when the white blood cells are broken down, it will result in the release of this leukocyte esterase. And this leukocyte esterase, it serves as a marker for the pyuria within the urine, and it has got sensitivity about 47 to 95%, and specificity of 64 to 92%. Now, the urinary another is a urinary nitrite. And the bacteria are more able in reducing the urinary nitrates into the nitrites, and mostly the gram-negative bacteria. And this, which will serves as a marker for urinary infection. Even we don't have the culture results, and this will somewhat somehow point out towards the evidence of some infection going on. And in the case of microscopic examination in the urine specimen, whenever we have got the 5 WBC per horsepower field, or the threshold of about 10 WBC, according to some guidelines, uh, it is labeled as significant. Now, regarding the culture, we have whenever we are sending the culture in the culture, it will take at least 18 hours to document any growth. And more than if we have a documentation of any growth, and we will start the antibiotics, and final result it will be after 2 to 3 days, and then we will escalate antibiotics according to culture and sensitivity. Now, the collection of specimen for the for the culture, how we should collect the specimen. And the specimen, it should be we have got certain methods, which was invasive and non-invasive methods of collecting the urine. And if the child is non toilet trained, and younger child, such as the infants, and it is very difficult to obtain the urine specimen for urine analysis. And then we have to go through the invasive methods like the suprapubic aspiration, like urethral catheterization. But and then we should send it for analysis. But if we are attaching the clean the bags for collecting the urine, and it has got higher chances of contamination. And regarding this collection of specimen, we should have certain precautions, and to have the uh, specimen which is free of contamination. Like we should have uh, there should be the washing of genitalia. There should not be the post fraction of the prepuce. And this, whenever this urine is it is obtained, it can be the result. It should be actually sent for analysis within the 1 hours, if it is at the room temperature, or it can be up to the 4 hours if it is refrigerated in the less than 4 degrees centigrade. Now, I as I defined in our previous slides, that the collection bake, it will result in the mostly false positive results, and result in the contamination. And I also described regarding this clean cage method, collecting of urine via more invasive methods like catheterization and suprapubic aspiration. Now, for the female child, there can be the two-person technique. The one person should have the gentle traction of the labia majora, in order to have proper exposure of the vaginal and the urethral opening, in order to facilitate the insertion of the catheter. And it is the last point. It is more important that the first few drops, which are mostly drained, and they should not be collected for analysis, because they may contain the bacterial contamination. Now, the method of suprapubic aspiration, we should have the 22 gauge needle that is above the pubic symphysis of the bone 1 to 2 centimeter, and then aspirating the urine. And through this suprapubic aspiration, the presence of bacteria greater than 10^5 is significant. For the catheterized child greater than 10^4, it's significant. Now, regarding the radiologic investigations of the child suffering from the UTI, can anyone tell me what are the investigations in the child we will perform in the child suffering from the UTI, starting from non-invasive or least invasive, and then we will progress to the invasive investigations? Is anyone from the class?
Shirsha, whenever a child present with a fever, what you do in emergency or with symptoms of UTI, with signs of UTI, what you do? What investigation you order? What you look for?
After taking history and doing proper examination, we are in the practice of sending urine culture of the patient and treating the culture. After that, to find if you are suspecting any anatomic abnormality or any lower tract problem, then we go for cystogram or MCUG.
First of all, you perform ultrasound.
Ultrasound. Yes.
First of all, it is the least invasive, no radiation exposure, inexpensive, and you can get a lot of detail on just on a simple ultrasound kidney ureter KUB. So
Yes.
what you see in an ultrasound in a child presenting with a fever?
We prefer to see the ultrasound with filled bladder, and we might see the distal hydrouretus starting from the bladder, echoes in the bladder.
Yes.
Wall thickness uh, can be it can be thick. Then in the upper tract, we might
Yes.
get hydronephrosis. Again, echoes in the pelvic ileal system,
And
and the kidney could be swollen
yes, and most commonly stones.
and stones. Yes.
So there are a lot of information you can just get on simply an ultrasound KUB.
Yes.
If thick wall bladder, bilateral distal hydroureter, upper tract hydroureter nephrosis, echoes, stone, swollen kidneys. So you can get simply on an ultrasound KUB. So next slide, we have short of time. Bilal, please go first. What are the next investigation? What are the gold standard or the next investigation? Yes, Dr. Tanveer.
Urine complete examination for pus cells and
Yes, we have done that. Now we are going into the investigation, radiological investigation. After ultrasound KUB, what you do? The child is having a suffering from a UTI or a recurrent UTI or repeated episode of febrile UTI. You want to assess what is the cause of these UTI. What
maturation
investigation you order?
cystoureterogram.
Sorry,
Maturation cystoureterogram.
what you see? What you
For
expect?
VUR or posterior
Yes.
urethral valve.
Yes. In a male child, you see for if the dilated posterior urethra, if there are picture of keyhole sign in MCUG, posterior urethral valve, trabeculated bladder, VUR, and so that is the gold standard. VCUG or MCUG is the gold standard for the detection of VUR. And if a child present with first episode of febrile UTI, we perform an ultrasound KUB, treat the infection, how much is the severity of the infection. If the child again present with a febrile UTI, you must order an MCUG. So there is another aspect of that. Professor Asad, sir, would you please kindly like to share your valuable opinion about the top-down approach or the bottom-up approach? So
it should be the bottom-up approach, and this is the principle in urology, whether it's an adult side, it's on the adult side or the pediatric side. So one must have a kind of a plan that the distal pathology should be treated first and then move proximally. Whether you are dealing with any kind of an anatomical abnormality or some kind of investigative protocol, it should be like that. Otherwise, it will be a jumbled up procedure or a plan. And many of the times, whenever somebody asks you, or in later part of your life when you become a consultant, if you are not in the proper way of thinking, then you are always writing down things from head to toe, everything on a piece of paper, and then banking on something that if anything is positive, it comes to you and then you treat from that side. So that is not which is known as cost effectiveness of your plan, and it will always be regarded as a bad reflection of anybody's diagnostic capability. So we as a surgeon or physician, we are always checked and guarded by our own selves, and whatever we do, the best judge is the patient. So whenever we deal patient, we should think of something called cost effectiveness, and we should always think of something, as we have said earlier on, going from non-invasive to invasive, and from down up. So this is the plan.
Yes.
So whatever comes in your way, whether it's a CT scan or MRI,
Yes.
or simply a UTI, there has to be a kind of an imagination which should be prudent.
Yes.
So, for instance, if somebody is thinking more in terms of having UTI because of the fact that P. fimbriae is somewhere expressed more, then you should be in proper consultation with a proper person, and that is that is a microbiologist. So there are ways and means of asking your colleagues to help you, but again, an intelligent question is something which must come from the doctor or the physician. The intelligent question should not be from the other side. For instance, a microbiologist won't ask you a question, they will need an answer from you. So your question has to be properly placed. Why your patient is having a recurrent UTI? So one thing is this. The second thing, I think that point was not mentioned, and that is COTI, catheter associated urinary tract infection, and that is very important. So whenever you see patients in on the adult side or on the pediatric side, you see a lot of patients with catheter inside, and a patient with a catheter and asking someone to rule out infection is always a problematic question. So there are algorithms now. If you go into the literature, recent literature, COTI is something which is regarded as a very important subject, and there is a very good kind of algorithm by which we can always diagnose those people who have got long-standing catheterization. Probably these patients like
Yes.
spina bifida, they always have got a very long-standing catheterization history. So these are some of the thoughts that I have.
Yes.
Next investigation, Bilal.
And computed tomography regarding this CT scan, we are performing whether through the in contrast media or the non-contrast CT scan. Regarding the non-contrast CT scan, which is very much valuable in diagnosing the patient suffering from the history of the urolithasis, which is not even evident or anatomical anomalies on the ultrasound. And regarding the presence of the contrast media in the case of the patient suffering from the acute pyelonephritis or renal abscess, in order to because both will present the areas of hypertension and the wedge shaped and loss of corticomedullary differentiation. So we will have the delayed images for the diagnosis of the UTI. The delayed images in the case of the contrast CT scan, and the radiation dose for the abdominal or pelvic CT, that is about 10 to 15 millisievert. The millisievert is the amount of radiation that is absorbed by the body.
How many can anyone tell me what is the principle of ALARA? What is ALARA? It is very important in a pediatric patient. Any candidate who is very near to exam? Numan?
Sir, as low as responsibly achievable.
Complete. Yes, you are right. What is ALARA? As low as possible radiation. So whenever you order investigation in a child, in a radiological investigation or radiation that have any radiation exposure, you must think about the Lara principle. You
Yes.
want to give as low as possible radiation to a child whenever you are diagnosing a condition. So CT has a high dose of radiation, so we avoid CT in a child, in a pediatric patient. Only if we desperately want to know a tumor, then we perform a CT or a radiolucent stone. Otherwise, we go for X-ray, KUB, or MCUG. Next.
Okay, this MRI. This actually MRI provides the image regarding the anatomical and the functional, but there are certain the problems the patient suffering from the UTI, in which we will perform the MRI. Because of the use of anesthesia and exposure of the radiations, and even in the patient having the impaired renal function due to presence of paramagnetic radiations, the patient will have the nephrogenic systemic fibrosis, but it is gold standard. It is limited in the higher cases in which we have got the doubt and suspicion of the patient suffering from the UTI. Now, next is the isotope scan. The isotope scan actually there are different ones such as the DMSA and the megascan. In the DMSA, whenever we want to have the cortical images of the cortical function or the differential renal function, we should have the DMSA scan. And because the DMSA scan, whenever we are injecting this dimercaprotasuccinic acid intravenously, it will bound to the proximal inner cells, and it will be excreted very slowly. So it will have the exact and excellent that is a cortical image in whenever we are performing in the DMSS scan. While if you want to know about the obstruction, the megascan, because it will provide somehow the image of the renal cortical function, but mostly it will tell us and give the image of obstruction, because it will be excreted quickly as compared to the DMSS scan.
So in a patient, if a patient is a VUR, we perform in a DMSA. On DMSA, we look for, Nadia, what you look for in a DMSA? Yes. And differential function of the kidney. So I was talking about, sir, regarding top-down or bottom approach, is about that. In our setup, we have an MCUG or a DMSA. We both have available of that. In top-down approach, it is thought that we first perform on a DMSA. If we find a reflux, if we find a scarring on a DMSA, then we perform an MCUG or a VCUG. In a bottom-up approach, we first perform an MCUG, and if we find a reflux, then we perform a DMSA. The difference is that because MCUG is an invasive study, we have a lot of patients who admit with post-MCUG fever or post-MCUG sepsis. So in order to avoid these post-MCUG fever, there is one theory that we perform a top-down approach. But both approaches have separate benefits and disadvantages. I think last few slides we have time up.
Yes. Regarding the management in the child who is with a toxic child and having the fever, raised TLC, and having or having the tachycardia, and the patient, the child who has the poor feeding or irritability, or the patient has got the low BP, and this, the toxic child, he will go under the admission in the hospital, and we will start the IV antibiotics, and followed by the urine culture. And once we will have the final result of the urine culture, then we will convert it the IV antibiotic into the oral antibiotic, and then discharge the patient based on the normalization of the parameters. Okay, there are certain antibiotics that are written. We are short of time, that's why I have to go through. And regarding the preventive measures, how we should prevent the UTI. There are certain general measures, such as we should have the adequate fluid intake, and there should not be constipation. And the patient, the child should have the timely voiding and the double voiding, and if the male child, he should be circumcised, and then we should
Prophylactic antibiotic.
yes, prophylactic antibiotic. The prophylactic antibiotics actually, when the patient is suffering from any urtic symptoms, and we don't have the evidence of culture, we are starting the antibiotics in order to affect unless we have the definitive result of the culture. And the prophylactic antibiotics in order to prevent the complications and somehow resolution of the symptoms. And the prophylactic antibiotics, it should be about 1/4 of the dose, should not alter the commensals, it should not be toxic. And there are certain factors in which we should not use the prophylactic antibiotics. It has got no benefit, like the circumcised child, or no bladder or bowel dysfunction, no history of the UTI, no anatomical anomalies.
What is breakthrough UTI? Last question. Amar, what is breakthrough UTI? So if we keep a child on a prophylactic antibiotic, and despite that, if a child experiences a febrile UTI, then it is called the breakthrough UTI, and it immediates management, it immediates the treatment of the cause of the infection.
After the prophylactic antibiotics.
It can be, but we give prophylactic antibiotic if we find a certain risk factor like a dilating VUR or a patient having any lower tract abnormalities. So that is why we give in a 1/4 dose. It can get antibiotic resistance, but we need to give it. Thank you, sir.
Thank you so much.